A recent cover story in CardioSource World News Interventions was called Radial Rising. And there is a paper now coming up in JACC that suggests maybe we should see a rise in falsification endpoints too. What's that? That's why I'm here, and that's why I'm talking to Neil Jason Wimmer, MD, a fellow at Brigham and Women's Hospital in Boston. Okay, explain the falsification endpoints to me. The paper you have is comparison of transradial versus transfemoral PCI, that I understand, in routine practice, evidence for the importance of falsification hypothesis. What's that?
A falsification hypothesis is actually a simple idea. It's something that's used in basic science all of the time, but not so often in clinical science. It's when we test something as a control hypothesis, something that we assume is not associated with the thing we're actually interested in this case comparing the outcomes of people who have transradial or transfemoral PCI, and we use what we call falsification hypothesis to see if the comparison is a valid one to make.
So how would it work?
So in this instance, we use an example where we expect that transradial PCI is associated with lower bleeding outcomes compared to transfemoral PCI. What we don't expect is there to be a difference in bleeding outcomes that are not associated with the access site itself, bleeding from the gastrointestinal tract or genital urinary bleeding, those kinds of things. And so we use whether or not there are differences in non-access site bleeding as a way to test whether or not there are underlying differences between the groups of people who have transfemoral PCI and transradial PCI. It's a way to look for what we call residual confounding in observational studies. Are the two groups equal?
And when you did this study with transradial versus transfemoral, what did you find?
We found that there are big differences even after we use the best statistical methods and the most modern statistical methods. Even after that, there are big differences in the population who get transfemoral PCI and transradial PCI. That tells us two things. One, that randomized studies are absolutely crucial in this population. And two, that studies that are not randomized based on observational data can be flawed even with the best statistical methods available.
Will statisticians know if the clinical leader of a trial, the PI, says, can we run a falsification hypothesis on this? Will the statistician know what he's talking about?
Not necessarily. This is a term that we in the medical world are way behind people who do this all the time, like economists. Economists don't have the benefit of being able to do randomized clinical trials because they're interested in things that you can't randomize people to. And so they have been using this for years. In the medical world, we've been lucky. We've been able to do randomized trials. And so most people who do biostatistics have not been familiar with using this kind of idea. It's kind of like doing a negative control in the laboratory, or it's something that economists have been doing for a long time.
So this paper in JACC should be read not only by the people doing the trials, the PIs, the clinical trialists, but by their statisticians too.
That's right. I think this paper, the use of a comparison between transradial and transfemoral PCI is just an example. This is an idea that should be very broadly applied across all of biomedical research whenever people use observational data.
Do you like doing research? I mean, you're a fellow, you're at one of the best institutions in America. Is it fun?
It's the most fun thing I get to do. I get to meet and interact with incredibly smart people, and we're trying to figure out ways to make things better for patients. It's incredibly fun. As part of the training program, I've both trained at Brigham and Women's in cardiology, and now I'm a fellow in interventional cardiology. But the research part of the experience is, I think, the most intellectually fun. I love taking care of patients, but this part is interesting in a way that I wouldn't get fulfillment just taking care of patients.
I was talking to an older doctor recently who's been around for a while, and she was saying that when she originally started, they told her it would be 80% clinical and 20% research. She says, really, it's 100% clinical, and you get that extra 20% during your weekends, your holidays, anytime. Is that kind of the way you're looking at it too?
At this point in my life, that's true. I was lucky that in the last few years I had most of my time protected to do research, and that was because the Brigham and Women's was lucky enough to have a training grant in order to be able to do that, and so I benefited tremendously by having some protected time where I wasn't having to do clinical work 80% or 90% of the time. I had the chance to really focus on doing research and take it in.
And is this paper one of the results of that?
It is. So
Well, this paper is in JAC, and I really suggest you go take a look at it. My son is a statistician, not on the medical side. He's one of the ones on the financial side who knows all about this, and it's like, please explain this to me, Aaron. This is the falsification hypothesis. Radial is rising, and maybe the use of falsification hypotheses should too. For CardioSource World News, I'm Executive Editor Rick McGuire.